the Physiatry Mentors. I'm Dr. Sheena Bhuva.
I'm Dr. Benecia Williams.
And together we are
Sheena.
Nice. All right. Well, today I'm super excited because we have two people who are very near and dear to my heart, Dr. Brad Sorosky and Dr. Susan Sorosky. Welcome, guys. They're hashtag couple goals, right? So they are married and they have a fellowship in Phoenix, Arizona called the Desert Spine and Sports Physicians. So today we'll talk a little bit about the fellowship and just what it takes to be a competitive candidate, and we'll maybe go into a little bit more detail about private practice if we have some time. So welcome.
Thank you. Thanks for having us.
Oh, Benecia, you're muted.
Get it together today. Hi, if you guys can go ahead and tell us a little bit more about yourself, tell us where you're from, a little bit about your training, and how you ended up in the subspecialty of sports and spine.
I'm from Southern California. I went to UCLA and then UT Southwestern, which is where I met my wife, Susan, in medical school. If you get in from out of state, Rossborough has a huge endowment and you pay in-state tuition, so it was my cheapest opportunity.
Oh, nice. I didn't know that.
And then I did my residency and fellowship at the Rehab Institute of Chicago. I think it's now called Shirley Ryan Ability Lab, and Susan joined me there as well.
And I went to Yale University for undergrad, majored in psychobiology and pre-med, and then went to UT Southwestern. I'm actually from Texas, so I went back to my home state and met Brad, who's a year ahead, and he introduced me to the field of physical medicine rehabilitation. No idea what that was about, so that was very fortuitous. And then we ended up going to the same residency he a year ahead at RAC, and then we moved to Phoenix after that and set up shop.
Nice. Yeah, so, you know, as you mentioned, so DSSP is a private practice, and oftentimes fellows are a little bit worried about doing a fellowship in a private practice. So if you guys want to kind of talk a little bit about that, and also just how is your practice set up?
Yeah, well, we mirrored it a lot on how we were trained at the Rehab Institute of Chicago. It's a spine and sports practice, and we're proud physiatrists. So, you know, we focus on function and returning people back to things that they want to do. And we're all encompassing. So we take care of people of all ages. Anything musculoskeletal, we manage. Our practice is probably 70% spine and 30% peripheral. As far as private practice goes, that was probably more in line with our kind of philosophy and being able to move quickly. I grew frustrated sometimes in academics and processes and committees. And we wanted a little bit more leeway in how we wanted to take care of patients.
Yeah.
Very good.
So, yeah, go ahead.
No, go ahead. I'm sorry.
Well, I was just going to say, you know, because I think Sheena mentioned something about how that is in a fellowship. So, you know, it allows us a lot of flexibility with our fellows. So in order to tailor our training towards what the fellow needs, they come in with different skills and they come in with different goals. And we're able to kind of modify that as the year goes on. And also impart, you know, information and skills about practice management, because that's not something a resident necessarily leaves residency with those kind of skills to do. And that might be somebody's interest. So.
Yeah, Sheena and I have talked about that in the past, and think that is definitely something very key to learn is the business of medicine, because it's very much a business, and you don't get enough of that in residency training. So to be able to get that in fellowship is wonderful.
Yep. And when I started my job, like they were super impressed that I already knew like everything about billing and coding, and it just made that transition so much smoother. So.
Mm-hmm.
Yeah, and when we say business, it's not, you know, how to make more money necessarily. You know, I think it's patient care first. Really, billing and coding is important. You know, how to market yourself, how to interact with other specialties. You know, those are all important things. You know, when you send a note, I think it's important to know what specialist you're sending it to. You know, that may be a different. You may modify it if it's going to a neurologist versus, you know, primary care or a spine surgeon. So that's all the stuff that we kind of try to put under that business umbrella rather than just the finances.
Absolutely. So this was the first year that NASH, International Spine Musculoskeletal Medicine Fellowship match. How did the accreditation come about, and what exactly does that mean for your program to be part of that?
Yeah, to take it a step back farther, there was first, obviously you guys are aware because I've known you guys for a couple of years, but there was the ACGME and then there was non-ACGME. And that was a struggle, I think, for residents to decide what was a better fit for them. Under the ACGME umbrella, there was pain and then there was sports. And I think each had its pros and cons. Pain, in large part, maybe you got enough procedures, although not all programs, but on the flip side of that, they were mostly managed by anesthesiologists, and I'm afraid that some of the physical medicine rehab docs lost their identity in those fellowships. They were doing electrodiagnostic studies. They may not get a lot of exposure to non-spine. They were getting exposure to sports. And then they were getting exposure to things like chronic pain management and cancer pain, which may or may not have been an interest to an individual. On the other side, there was the sports ACGME, which I think did a good job in training in history and physical exam and diagnostics, but maybe you didn't get all the interventional skills that you wanted. So, and then on the other side, there was the non-ACGME, which was where we fell in. We were spine and sports, and we felt that we were training docs to what society and the community needs. Someone, if you hurt yourself and you don't feel good, and there's something wrong with your body, you don't have to think about it. You just go to this practice and they'll get you on the right track. The problem with that was that really expanded and expanded, and there wasn't maybe a lot of, what's the word I'm looking for, consistency and across all those 9 ACGME, and were they all giving really good training opportunities for the fellows. So NAS came about because of that, to really try to standardize the curriculum and make sure that all the programs were of a certain level. So a fellow felt confident if they went to one of these programs that they'd come out well-trained and able to hit the ground running.
And we've been, NASA's been in the background for a few years, and perhaps even when Sheena was with our practice in terms of a curriculum that we were following loosely in terms of didactics and education. But it's finally taken its shape now, and we're having a formal match this year, which is nice to even the playing field between the candidates and practices. And it also will present more standardized experience for the fellow, and perhaps more interactive, although the information we have is still taking shape. That we might be having interactive journal clubs between the practices and other kind of didactic experiences, and much more standardized repository of literature to go through, et cetera. But it's difficult, being a part of NAS. So, being part of NAS accreditation isn't just, signing up and wanting to be a part of it. You'll have to meet certain criteria in terms of scholarly activity, what kind of education, different kind of lectures presented, other kind of involvements in societies, et cetera. So there's a point scale to be part of NAS and to keep being a part of NAS. So hopefully that continues. We're one of the few private practices part of it. So
that's a big deal. Awesome.
Yeah.
That's really cool.
All right. And so I know, we all keep hearing, just the other day, there was an article that said the competitiveness of PM&R has increased significantly. I think it's now one of the most competitive specialists for DO students. So I'm sure you have seen that in the applicants that have come in. I don't envy you guys having to choose, who you guys are going to pick as your next fellows, but what do you guys, specifically look for in an applicant who's applying to your program?
Yeah, I mean, this year is an incredible applicant pool. I mean, the NAS Association has really done a big difference in terms of the applicant pool, and I think in general that people are applying to spine and sports medicine fellowships. In fact, we finished our 20th Zoom interview. It was just hard to differentiate on the applications coming in, and we needed to meet these people in person. And had it been otherwise, we would have had them come out to us. But with COVID, we conducted that on Zoom.
Yeah, so first, it's incredible how much PM&R is advanced. Unfortunately, we're getting old. So we finished in 2005, so we were 15 years in, and it was us and maybe psychiatry that were at the bottom of the barrel. Nothing against psychiatry, but just, it wasn't attracting a lot of the star medical students, and things have changed. And we see it now manifest in the applicants for the fellowship. Way more competitive, which is exciting to see. Yeah, so. Yeah. What we look for. Oh, what we look for in a fellow. Yeah, so, it's interesting. I think when you get into medical school, so much of it's about numbers, right? You have to have the straight A's and the MCAT score, et cetera. As you move up the ladder, I think in residency and fellowship especially, personality makes a huge, or that's a big factor in who we decide. We spend a lot of time with the fellow. We want to get along well. And then, on that front, they're also a face of our practice. They're seeing a lot of our patients. We work really hard to build up this practice, and we want to make sure that we maintain it and continue to grow. So that fellow needs to, I think our current fellow gave 2 adjectives that he thought was important. I concur, and that is calm and confident. I think that's what patients are looking for, right? They don't want to see a doctor fidgeting and nervous and unsure of themselves. It makes them nervous because they're already very vulnerable when they come to see us with an ailment. So I think personality is really important. There's some other traits that Susan thinks are really important too.
Oh, well, we get this question a lot, but teachability is probably the most important thing. And that's hard to gather, certainly in a 1-hour Zoom interview and even two days with an applicant were to be in person. But teachability, and just, I use the word being a sponge, because there's a lot of attendings, at least in our practice, there's 4 attendings that the fellow interacts with. And while we all have a similar way of approaching things, we all have a little bit different nuances. And so the fellow needs to be receptive to a lot of ways of doing the same thing. So they can choose for themselves when they want to go out on their own and see what is the best way that works for them. But just the ability to be a sponge and soak it up. And as well, we tell fellows we're soaking it up from them. We're all very humble, very open to learning. And I think everyone has an opportunity to teach everybody in the practice.
And then, as we describe this perfect fellow, Sheena comes to mind. She was she definitely
right.
The other thing, that Dr. Bhuva was incredible at is, trying to think about what's the next thing that's going to happen, whether it's in the procedure or the clinic, anticipating it and then helping, right? So some residents, you guys have trained residents in medical students, they kind of sit in a chair and they wait to be told. And then others kind of think, oh, I've seen this, the next thing we need to do is draw up this medication or clean the table or what we have. And, the person that kind of anticipates that and then takes action, it makes life better, and it kind of sets the pace and sets the tone for a successful day.
Being proactive.
Absolutely. That's
important.
Proactive, because a lot of times, if a procedure's not been, for example, we do kyphoplasties. Do we do kyphoplasties every day? No. But there's certainly a fair amount of exposure in a given schedule. But if that doesn't intersect with that person's schedule and they see another attending has a kyphoplasty in the schedule, they need to be not aggressive, but putting themselves out there and saying, hey, I need to learn more of these kind of things. I need to get into the procedure room, and we're being flexible in order to accommodate that. But it takes a little gumption on the side of the resident or the fellow to do that too.
So as you mentioned, you guys have been doing Zoom interviews before we started. You've done quite a bit of them already. How has the COVID pandemic affected that? And do you feel like you're being able to know the fellows in that short amount of time? I know it's hard, right? I can imagine.
We usually do 2-day interviews. So I'm the fellowship director, so I'm in charge of looking at, an application usually has rosy letters, a wonderful CV, everybody, all the research that everyone's being put into their applications, and it's very impressive. So we decided to interview quite a bit of people this year because of COVID, right? So we interviewed 21 people.
Yeah.
But it's hard to get to know somebody in that period of time, and we might have a few questions to throw out at them, and if that goes well, it's great. If not, it's a little rattly. We try to keep it calm and open and a dialogue in order, like Brad said, to kind of get to know their personalities, since that's really, really important. The NAS fellowship application also allows us to see other things like USMLE scores, et cetera, and sometimes SAE scores are presented. So that kind of extra information is helpful too, but it doesn't take, it's not at all a replacement for seeing someone for 2 days. But.
Yeah, it's hard because as you talked about, the personality is huge and seeing how you fit in with the practice. So we have medical students that are coming into our clinic right now, but so many of them, the schools have cut off rotations completely. And I'm like, I feel so bad for them, because that's how you really feel what residency or fellowship you owe the departed being able to go. So it's going to be interesting. So that's why Sheena and I decided to do this, to hopefully just put some information out for medical students and residents, so they know what opportunities are available to them.
And we were hoping that we'd be able to open it up for in-person, but it's in Arizona as it is in Texas. It's pretty bleak. So we'll have to do for this year and cross our fingers. And,
I think, unfortunately, you're going to see more residents staying at fellowships that are at their nearby. I think more people are going to be selecting known entities because known is bigger than usual, which is kind of unfortunate.
Yeah, I totally agree.
Go ahead. And we're also grateful. We have a big network, and we've been around obviously a long time. So we also rely on, knowing who's at what program that might know somebody. And I've bugged Sheena quite a bit about, do you know this person? And I have to rely on other people's word of mouth too, because obviously the letters of recommendation are really, really nice, but they don't differentiate people very well. So it helps me rely on something.
Right.
So.
Physiatry is a small field, so you gotta, always give a good impression.
Absolutely.
You don't know who knows. Who knows who, so.
Very true.
I was on our last Zoom. We were talking that you guys were going to be on, and I said, I remember when we met Brad at the residency fair. I said I was Sheena's hype woman, and I'm like, she's amazing.
Remember that so
Benecia's. Well, along the same lines with the fellows, has the pandemic, affected their education, and what about their job search?
Oh gosh, on the job search, I'll hold off on. So, their education for like a week, we shut them out of the procedure room just as we were kind of trying to figure out the next step, and we wanted to reduce kind of any crowds, including in the procedure room. After a couple of weeks, and then we wanted to save gloves too. We were trying to kind of figure out this PPE thing and the shortage. Obviously, we wanted to make sure that we were contributing to a shortage. So as we realized that gloves are our main PPEs, we felt more comfortable going back into the procedure room. Obviously, we switched almost entirely to telehealth for our clinic, and then we always have a high threshold for procedures, but even a higher threshold. So that's how our clinic, we're kind of lucky, I think, we slowed down and then it's been back up.
But I don't think the fellows experience.
The fellows experience, I think, was minimally impacted. We're really proud of that. One of the things for our fellowship that we understand is it's a huge sacrifice. You've trained, so long through residency, and then now you're taking another year. You're being underpaid, quite frankly, for your level of education. And so, we want to make sure that the fellow gets a good experience, and that it's worthwhile, that sacrifice that they're taking for that extra year. So, that carried through the COVID as well. As far as our fellows and jobs, one staying with us, so that wasn't significantly impacted, but our other fellow, it's awful actually. I mean, he interviewed at 5 places, got 5 offers, took a job, and then they took away the job
because of
COVID. It had nothing to do with him. He's incredibly good candidate. So he's actually going to stay on with us for 6 or 7 months. We're busy enough that we were able to take him until he can probably go back and join that practice. But that's brutal.
Yeah, I've been hearing all sorts of stories. Yeah, about offers getting taken back and.
Yeah, that was it. I mean, the offer, it's there, it's signed. I don't know the legality of all that.
Right.
But obviously, our current fellow, he's a really sweet guy, and he's not going to come out. Lawyers, etc. That's just not his personality. Plus, he eventually wants to move into that market. I'm not sure that's how he wants to, get himself off the bat. I mean, it's just so that big practice. I'm not happy. They could have handled that better, much better. But
I have a friend that's in Arizona, and she works for a large group. She's PM&R Sports, and she's guaranteed salary, and they took 1/4 of her salary away, which was a lot of money. And I was like, don't sign it.
I mean, but the money's not coming in. It's tough.
Exactly. Yeah. It's hard.
Yeah, and if elective surgeries get shut down again here, it's going to be a bloodbath, I think. Mm-hmm.
I know, that's what's so scary. Yeah, and just with the numbers rising, you just don't know. Especially for all of us in private practice. I'm like,
yeah. You think that doctors are, immune to recessions, but I guess pandemics can hit us in some capacity.
Yeah, we are not.
All right, you guys, go ahead and type in your questions. Do you have any questions for Dr. Sorosky?
I have a question for you guys. How many interviews do you think that the fellows should try to do now that they're doing everything Zoom? Before they were probably limited, on how many you could actually fly to with time and money?
Well, I mean, you can match 10 programs. So, I'd say as many as they can. It just gives a reference of perspective in terms of what you're looking for, because you might not know what you're looking for. Or you've probably only had or mostly had an academic experience, an academic center experience, and you're not quite sure if that's where you want to go, private practice or big or small groups. I think you don't know until you start talking to people. So I'd say as many as you can get your hands on.
Yeah, I think too, you have to be honest with yourself and how competitive you are. Like when you apply to medical school or to college, if you have a 4.0 and a 1550 SAT, you can be a little more confident applying to less schools. That wasn't me. So and then the programs, unfortunately, I think right now, if you're in maybe a bigger name program, and I think that changes too. I don't even know what the best programs are these days, but that helps a little bit too. There's a lot of really small programs out there, and it's tough for us to gauge what someone's training is right now, right? For a program that's 1 year old. And so, and then we don't get to spend as much time and we don't want to be too mean and really pimp them on a 30-minute Zoom call. So that person probably has to apply to more, than someone that's going to, a bigger name program.
That's a good idea. Yeah. All right, well, James has a question for you guys. So he says, I understand when you do an ACGME fellowship, you can get board certified through ABMS. So like, sports medicine or pain medicine boarded. Since spine fellowships are non-ACGME, what is your opinion on non-ABMS certifications after fellowship, such as the ABIPP or the ABPM?
Oh, these are good questions. So, this kind of goes back. There was an article published in the PM&R journal. It's been quite some time. It was a point counterpoint.
Yeah, we talked about that article. Yep.
Yeah, and that article I think will stand the test of time. It was very, and I read it. I was like, this is exactly right. So the question is how important is it to be boarded? I think in pain, I'm boarded in pain still. I'll let it expire. I won't recertify. I think it does nothing for me. In fact, if anything, I don't tell anyone anymore I'm boarded in pain. I tell people I'm a physiatrist.
I didn't know.
I'm very proud of that. I think being boarded in pain connotes that you write opiates, which we never have and never will. I mean, we do. Someone comes in with a compression fracture, of course, we'll write opiates. But we're about short courses of opiates, or very, very low doses. I think we all know that high doses is not a good course of action. So I think being boarded in pain, honestly, makes people think that you should be writing opiates. And I don't really know that it adds any business. The other issue is credentialing to surgery centers and hospitals. And so I think that is a fear that may or may not be valid. I know in Arizona it's not. The cruel truth is kind of money talks. And if you're well trained in procedures, every surgery center, every hospital wants you doing procedures in their facility because you're going to make them lots of money.
A lot of money.
And this is something that a private practice fellowship, I kind of explain to people how this all works, because I kind of get it because I'm not shielded from it. But anyways, so if you're well trained and you can show that you've done the numbers and you have someone signing off, you can be credentialed anywhere. Now, those other pain boards, again, just like even the one that's the American Board of Medical Specialty, I don't see any value in any of them. But maybe someone else, if they have a different goal in their practice, then maybe it makes more sense.
Yeah, probably out of fear, I did became a diplomat, American Board of Pain Medicine. I've hence let it expire. I don't know if that allowed me to do a procedure in a hospital. I don't think it did. I really don't think it has any bearing, and doesn't currently because I don't have it anymore. But I agree that association with being pain medicine or pain management it can be a negative one. And if you're practicing the way we are.
Definitely, I agree. I think it's important if you want to do academics or maybe, you know, working at a university, but I didn't have any issues from it. Like you said, they just look at your procedure logs, your numbers, how many procedures did you do in fellowship, and that's all really they needed. Yeah.
And the reality is some that are ACGME don't even get as many, right?
Exactly.
So that's
exactly.
the other,
yep.
you know, issue is that, you know, not everyone is getting those numbers in ACGME.
Definitely. All right. Any other questions, guys?
And I wanted to kind of piggyback on what you had said about doing, do you guys do many procedures at a hospital?
We did it initially. So initially when we were in practice on our own, we were part of an anesthesia-based pain management practice when we started for a couple of years. But when we started on our own and we weren't set up to have a fluoroscope in the office, we did procedures in a hospital-based setting and then in a surgical center, and then brought that in-house.
Right. And I don't think people also realize, like, for patients, it's significantly cheaper to not do it inside of a hospital. So once you do that, you'll realize that.
$50 copay versus an office copay.
Exactly.
It's staggering the difference. And
it is.
The rigmarole in terms of getting a procedure, you know, signing a DNR and being there for half of the day, and then being a really big deal procedure.
Yes.
The convenience of it in the office is very nice.
Yeah, and turnover time at a hospital, you will be able to do way more procedures at a procedure suite than at a hospital, because they're turning it over the room like a OR, so you'll be twiddling your thumbs when you could have done 4 injections by now. So
everyone's
that's
in a
something
gown.
else to consider.
Yeah, they have a stretcher.
What's shocking in the amount of waste, for example, when you do an injection with isoview, we use an entire bottle per one patient, toss it out, and then that's given over to the patient in terms of cost.
Yeah, and the bicarb.
So one more point on the last question with the ACGME is we all have biases, right? And so we're not ACGME, so I'm giving a bias there. But similarly, your residency is ACGME. So when you ask those attendings, should I do ACGME or not, you're getting a very biased answer, right? So I think you just want to recognize, you know, who you're asking the question. I'm biased and they're biased, but you know, I think a lot of people are getting the understanding that maybe ACGME isn't right for everybody, but and those residency directors, I think, underestimate what we're doing in private practice. You know, I think they assume, you know, that we don't ever read journal articles again and we don't stay up to date, and I don't think that's always true. And then next on your question.
Well, can I ask one more thing on that? Well, and NAS, I think, changed that. This was the first year I haven't barely heard the question. Every year we interview fellowships. We've had fellowship for 8 or 9 years, and that's a question that we get repetitively. This year, I'm not sure that we even heard it once, maybe once out of 20 interviews. So because of the NAS affiliation, it almost filled that gap really importantly.
So, and then as far as the setting for procedures, I think it's a really good question for residents to understand too. So you have in-office, you have surgery centers, you have hospital, and roughly speaking, the cost to the patient. So, you know, a lot of times people at surgery centers and hospitals, they'll justify exorbitant fees because they say the insurance covers it. Almost everybody has a high deductible plan now. So really it's the patient that's paying it, right? And that leads to higher premium. So the cost of doing a procedure in a surgery center is usually 10-fold of what it is in an office and 20-fold in a hospital. And then, you know, the other thing too is I think it creates a certain level of fear for a patient too when they're treated like they're getting open heart surgery and they're getting an intra-articular hip injection. When you go to a hospital, literally they're being wheeled in a gurney, and it's insane. I've also had patients that are 400 pounds and they won't let me do a surgery. They won't let me do a hip injection because their BMI is too high and therefore they're too risk to have surgery. So yeah, that kind of goes back to my original reason why I went into private practice.
And the reimbursement is way different too, right? And what you guys get to keep when doing an injection at an ASC or a hospital versus in-house.
And so this is something that I had no idea when I was a resident. So when you're in office, you get something called a site of service difference. So you keep the entire amount. So for an epidural steroid injection, a single level transforaminal for Medicare, we get paid probably, I don't know, in the ballpark of about $300. And that has to pay for your whole overhead and all the supplies, pretty much the fluoroscope. Nurse, yeah. So when you're in a surgery center, you get paid, I don't know, $80, $100 in that ballpark. That's your professional component, and then the facility will get significantly more, usually in the thousands. But if you own the surgery center, obviously that can be lucrative, but often you don't, or you have a small portion. So you get a much smaller piece of the pie. And the same thing holds true for the hospital. Mm-hmm. The other thing too, I think for residents, that are looking across the country, is there's huge differences in parts of the country. That was something I had no idea of, when I was a resident. And I don't know how much that matters to people, but from malpractice to reimbursements to there's a lot of those things, and it's hard to understand each market, I think, but they are, and something that someone may want to look into if they have some openness in where they'll ultimately end up.
All right, so Carter asks, is it recommended or common to do an away or audition rotations during residency or fellowship?
I'm not in our practice, so I can't really speak to how common that is. And we get the requests sometimes, I think, about that in our practice. Not very often. It's just we're very busy with our practice and our physician assistants and the fellows experience and the patient experience. So we don't have that. It's certainly not at all necessary. It's not something that I would look at all.
Yeah.
Yeah, and it's hard, Carter, in residency to do a rotation outside of what is already set, because it has a lot to do with like malpractice, what is covered during, and where your paycheck is coming from your hospital. So they want you associated with that hospital. Sure. So it's very difficult to do in a way during your residency.
And procedurally, like if you're in ICP, some of our applicants do rotations. It seems to be easier to get needle time or experience that way, within their own hospital system for that same reason in terms of insurance coverage.
Mm-hmm. I think if you're interested in a program, though, you could, parlay a weekend and call the program and say, hey, can I shadow you guys on a Friday or a Thursday? I think if you wanted to kind of push yourself above the competition or introduce yourself, that'd probably be better to spend a day or two. It's a little less imposing too, because like Susan said, our practice, our goal is to make sure the fellows, that's our priority. And then, we also have PAs that we're overseeing as well. So it can be pretty busy to tack on another person.
No, I think that's perfect. Take a couple of vacation days and go check out the programs. And to kind of piggyback on your point about just a private practice in the NASDAQ, how many people didn't know about these private practice fellowships that are out there? I was very fortunate to have a wonderful classmate, Dr. Bhuva, who we researched a lot of programs during our PGY3 year. And because there's some programs that are great, and there's some private programs that are not so good. So definitely do your due diligence and research every program that you're looking at. Ask to talk to their fellows that have graduated, see where they're working out, ask them how many procedures that they got during that year. All those things will come in handy when you're trying to make a decision.
Absolutely. All right, well, I think our questions are dying down.
Well, we appreciate you guys taking the time and coming out on a Saturday.
It's so nice to see your face.
Yeah, it was so good to see you guys.
No, maybe when PM&R opens back up, we'll get to see each other in person and go to lunch, all of us.
Virtually this year, however that is. We'll be at the fellowship fair virtually. I'm not sure what that's.
Yeah, are they still going to do something like that? We're going to
do the job and fellowship fair still.
Yeah.
I'm not sure how that.
We got an email, I think 2 days ago. I didn't read it yet, but
not the specifics out there yet, but it's happening.
That'll be interesting to see. Yeah.
That's interesting. It'd probably be like online dating. Like people float through your Zoom room.
Like speed dating.
Yeah.
See, internet feeling on this.
Together for 20 years. We don't know online.
Right. Yeah, well, I'll fill you in. So this is very good. Yeah, join us tomorrow, everyone. We have Dr. Kristen Taylor on. She is a pediatric PM&R physician, and she went to medical school with me. She's great, and she's going to fill us in on pediatrics and CBD. She's an expert in CBD. She was very pivotal in getting the bill passed in Texas to have spasticity treated with CBD. So yeah, we'll ask her some questions about that.
Yep. So everyone, thanks for joining. You know, as always, you can follow us on Facebook, IG, and this video will also be on YouTube, so you guys can share it and watch it there as well. You guys have a great weekend.
Thank you, guys.